thank you, Gupta sir, and the team for inviting me to be a part of this symposium. I'll be switching off my video just not to interfere with my the audio. So this talk of genetics of CAKUT was given by Professor Francisco Emma from Bambino Gesù, and I have a privilege of knowing him personally very well, and also have spent some couple of weeks in his hospital a year back, much before the corona hit that country first. When we talk of genetics, I mean, we especially in the field of nephrology, we think of steroid-resistant nephrotic syndrome as one of the most common etiology, where we do a lot of genetic workup. And then comes the tubular disorders, and then the ciliopathies. CAKUT is never seen very up in the list. And over the next 12-15 minutes, I will be going through the review, and which will give an understanding of the utility and the current status, as well as the challenges of using genetic testing in children with congenital anomalies of kidney and urinary tract. And I've divided this talk into 2 halves. The first half, I'll be talking about the clinical aspect and a bit of embryology, because it's important to know that in the context of genetic testing, and thereafter going into the core genetics and the how we could use it in the current setting and the challenges. This CAKUT is a term that has been used for the last decade or so, which is an umbrella term for a spectrum of renal anomalies, not only the kidneys but also the urinary tract, and they're usually the structural, and many of them are functionally normal, but in a subset it could be functionally abnormal. And they represent one of the most common congenital malformation detected by fetal ultrasound, and with an estimate ranging from anywhere between 3 and 6 for every 100,000 birth. The kind of the anomalies that are seen varies very much, and not only are they seen as an isolated, but also in presence of other extrarenal malformations. So when we look at the phenotypic spectrum of the renal, it's really diverse. But broadly, we could classify into 3 groups. One is basically the reflex or reflex nephropathy, where there may be associated dysplasias, and the third group is the obstructive uropathy, and most common representative example is posterior urethral valve. So as you can see, it is very diverse, and fortunately, most of the anomalies that are detected antenatally are transient or physiological. But yet, we need to worry about the spectrum of anomalies in children, and I'll come to that in the later slides. So, as I said, I mean, we just need, when we talk of CAKUT, we need to look beyond the kidneys, as shown in this cohort study of 100 children, where they noted that nearly 1/3 of them had extrarenal anomalies, mostly involving the cardiac, the hearing, and the amount of diabetes mellitus, especially those with HNF-beta mutations, ocular, and ear anomalies. So it's very important that when we have a child with CAKUT, we look for these extrarenal anomalies, and vice versa. When we have a syndromic child, we need to look at the kidneys by performing an ultrasound. So these are some of the examples. Like this was a child who presented to us with renal failure, but obviously on examination was obese, had short stature, had polydactyly, so was a child of Bardet-Biedl syndrome. And similarly, when you have a child with a renal dysplasia, you should do a careful eye examination, like as this in this child, where you can notice a coloboma. So extrarenal findings helps us identify a probable genetic etiology of the underlying CAKUT. So why should we bother about CAKUT? As you see in the left panel of the slide, from various registries that represents various populations we can see that CAKUT constitutes probably 30 to 50 up to 60% of causes of CKD or and the most common causes are hypodysplasia, what is seen elsewhere. This is the data from our chronic CKD clinic, where you can see that renal hypodysplasia, obstructive uropathy form a chunk of those children who present with CKD. While most of the structural malformation can be picked up antenatally, in Indian series from JIPMER, when they analyzed 300 children with CAKUT, they observed that 1 in 5 children are diagnosed postnatally, especially when they present with urinary tract infection, hypertension, or other non-specific features of CKD. And CAKUT with CKD clearly impacts the quality of life, and many of these children gradually progresses to end-stage renal disease, often between 15 and 25 years of age. As you can see, although it constitutes the overall in the European registry, it constitutes only just 2% CAKUT for those on dialysis. But you can see that majority of young population who enter into dialysis have underlying CAKUT. So it's clearly suggesting that CAKUT is associated with significant morbidity and mortality also, which have not shown that they tend to have a lower survival as compared to a glomerular disease. There are many unique aspects which are reflected on the genetic aspects of CAKUT. Many of them are unilateral diseases. They can be sporadic as well as familial. And also there is high phenotypic variability between cases even within families. So one child can have reflux where the mother can have cyst in the kidney, or the other child can have PUV. And not only between patients, even within the same individual, there can be co-occurrence of different for example, a child with renal agenesis or CDK can have a kidney. So clinical phenotypic device dynamic and that possibly is probably a significant role in deciding the severity of CAKUT. And this environmental is well known in Barry Brenner's study of subtle kidney hypoplasias, where now we know that a large number of causes like prematurity, diabetes, medications, vitamin A deficiency can all lead to subtle dysplasias. But now I'm going to focus solely on the genetics of the CAKUT. Before I go into this genetic, it's important to understand through the embryology why the genetics is very complex. There are two key events happening, that is from the two key players, that is the ureteric bud and the metanephric mesenchyme. And the induction of the ureteric bud, the metanephric mesenchyme, leads to further branching and nephron development, which begins at 4th week. The ureters get canalized around 6 to 8 week, and urine formation starts around 8th week of gestational life. And thereafter, there is gradual maturation and formation of more and more nephrons until the 36th week of pregnancy. So as you can see that there's a continuous development of the renal of the genitourinary tract, and the timing of insult will determines the kind of anomaly you have. So if you have an insult in the early gestation, it's more likely to be agenesis or severe hypoplasia, and if it is in the later half of gestation, you could have more of the outflow tract abnormality, which coexist with varying degree of kidney hypoplasia and dysplasia. There is more granularity in the morphogenesis, the molecular players involved in the morphogenesis, basically more in the nephron development. As you can see here, the nephron goes through various stages of development, starting from the condensation to the vesicle formation to gamma shape, S shape, and then invagination of the capillaries into the glomerulus, and finally forming the mature glomerulus. And there are a lot of transcriptional factors that regulate this development. Similarly, in the ureteric bud, there are a lot of molecular players that are involved not only in the metanephric mesenchyme, but also in the development of the ureter and the urethra and the urinary bladder. So this complex process requires a very tight regulation of the entire transcription process, which is not only different in different nephron segments and the ureter, but also is very time dependent. So a lot of this phenotypic spectrum that we see is also based on which of these molecular players are involved, are perturbed, or are affected. But what is not very clearly known is that apart from the glomerular formation, the exact patterning of the remaining segment of the nephron, including the distal connecting tubules and the collecting system, is not very clear. Now, before I go into the genetics, I just want to highlight two terminologies and two techniques. As we all know, the genetic variations, most common are small point mutations or insertions and deletions that we commonly see in most of the inherited diseases, including renal diseases. And these could be detected using either Sanger sequencing or what is now we commonly use the next generation sequencing. But there are other group of variation that are very large. That is, they involve thousands of bases of deletions or duplications. And these are called copy number variations. So there are large structural variations. And these can be only identified if you do a chromosomal microarray. And why I'm saying that this is that a lot of variations, genetic variations that have been identified in CAKUT encompasses both these type of variants and hence requires two different type of techniques to detect these mutations. This slide shows a list of genes that has been identified with CAKUT. There are more than 50 genes, and what is striking is that the dominant genes are more predominant as compared to the autosomal recessive, which makes a genetic diagnosis using NGS challenging. It's far easier to diagnose a recessive condition using an NGS method as opposed to an autosomal dominant method. The other thing is the most common mutation that have been identified are PAX2, 6 genes, and then the TNXB. By genetic testing, we are trying to pick up which of these genes are mutated in a child with CAKUT. So to know which are the common genes involved, I'm giving a summary of various studies that have been done. The number of genes that are causing mutations varies on the cohort that has been studied, the number of genes that has been screened. And these are the common genes that have been identified, as I've said, PAX2, ROBO2, HNF-beta 6, and ERA-1 are the common genes associated with renal hypoplasia and dysplasia. Very few genes have been associated with ureteral anomalies like ROBO2 and UPK3A. Now, these, especially in hypodysplasia, nearly 10 to 14% can be explained by mutation in any of these genes, which has also been validated in other large cohorts like the CAKUT cohort from US. And also when they screened severe renal anomalies in fetal autopsies that have severe fetal renal anomalies, they found that HNF-beta and PAX2 are the most two common mutations that they could identify. So while a single gene technique can identify few genes, with the advent of the next generation sequencing, more and more genes are being identified. And this is an example of whole exome sequencing done in one of the largest cohort of children with CAKUT, 232 families with nearly 500 children. What you can see is that around 13 to 14% of the children were identified to have mutations in this cohort. That includes 6% of children with a known syndromic CAKUT gene. And also they could identify around 10 patients, 10% of the patients having novel multiple candidate genes that needs to be further validated. And this panel on the right side, other groups who do not have history of consanguinity or a severe phenotype. So this is clinical information is important to keep in mind while ordering a genetic testing. What about adults? This is the data from Irish cohort where they screened for in 18 to 20% of their population of adult onset CKDs with CAKUT had some form of a genetic mutation. And you can see again here what was seen in children, that if you have a cystic kidney disease, if you are syndromic, and if there is an isolated CAKUT but with a positive family history, you are more likely to have a identification of a genetic etiology. So this is something which is very simple. Genetic testing is something, the burden is similar as seen in children. So we tried to look in our cohort the burden of the prevalence of genetic mutations, and we screened 69 children with a customized design panel that we designed in our lab that involved only 31 genes, just to save cost, as whole exome sequencing was expensive. We ran this panel on an iron torrent sequencer. And this is the clinical details of the cohort. Bulk of our patients were with vesicle reflex with or without dysplasia and posterior urethral valve. And when we analyzed the 31 genes in these 69 patients, we found a large number of variants, but based on the criteria that are used to identify a pathogenic variant, we finally filtered 63, and among them we found only 3 variants to be likely pathogenic, while the rest of it were either variant of unknown significance or likely benign. And these 3 variants, 2 of them were seen in one patient who had PUV in the CHD1L gene and TNX found to be mutated in a child with left duplex ureter, suggesting that not only there is a phenotypic heterogeneity, but also a genetic heterogeneity in the form that the same gene can lead to different type of phenotypic manifestations. Apart from single gene mutations, what has now been identified are that there is a significant number of CAKUT where copy number variations are involved, which I have already said that there are large deletions across many genes involving more than 1,000 base pairs. This is one of the largest studies done in US, which involved close to 3,000 patients with CAKUT and 21,000 control. And you can note that it's a different technique. It's called a microarray technique. And they found that CLBs are seen in 10% of the patients. And most commonly, they are again with renal hypodysplasia, mostly deletions. With reflex, there is a high burden of CLB, but there are mostly duplications. And the least number was found in posterior urethral valve and other obstructive uropathy. So again, suggesting that there are genetic heterogeneity and differences in the architecture and the development of the renal tract, and also that different CAKUT categories are genetically distinct. So just to summarize that from all the studies, monogenic causes can be seen in around 15% and CMV in 10%, which means that a large number of patients do not have a genetic diagnosis. Again, it requires 2 different methods to detect these variants. The variants identified have incomplete penetrance and variable explicitity, resulting in a phenotypic heterogeneity that makes counseling very difficult. And the genetic yield is highest if the child has a renal hypodysplasia as opposed to a child with PUV. And also what has been noted is that many of the children with CAKUT can present with different manifestations like severe proteinuria, which can be steroid resistant, or you can have a small contracted kidney, which on genetic analysis, it turns out to be Alport. And what is surprising is that unlike in steroid-resistant nephrotic syndrome, it seems that the burden of mutation is similar in children and adults. So what does it mean from a clinical practical point or from a clinician's perspective? It means that there are major challenges in the use of genetic testing because of lack of strict genotype-phenotype correlation. You should order genetic testing in a child with CAKUT if they have syndromic features or a family history or history of consanguinity, and if they have a severe renal hypodysplasia. And the most obvious clinical implication of using a genetic testing is that it allows us to do something called a reverse phenotyping, wherein suppose you find a child with a FHNF beta mutation, you could look for uric acid level, magnesium level, you could look for abnormalities in the liver or pancreas. Similarly with PAX2, you could go back and look into the eyes to find whether the child has coloboma or not. And what is also known is that many of the CNVs are associated with neurodevelopmental delay and other cognitive defects. So these children can have poor scholastic performance or delayed in very many of the milestones, which was initially attributed to severity of the kidney disease. So these data shows that the study shows that there are no strict criteria to order genetic testing. But however, in patients, there are criteria that has been developed, especially for screening for HNF1 beta. As you can see, there are major criteria, especially if there are fetal bilateral hypogenic kidneys or cystic kidney disease. And if you have a positive family history and some of an extra renal criteria, then they can have HNF1 beta mutation. So as you can see here, if you have 2 major criteria, along with hypomagnesemia and cyst of unknown origin, the odds of finding HNF beta is much higher as opposed to a child who has a unilateral CAKUT or no major renal hypodysplasia. So in summary, any fetus with a bright hyperechogenic kidneys that are normal in size, or any child or an adult who presents with cyst in kidney of unknown origin with a normal kidney size, you should think of an possible H1 beta mutations. So how do we now improve upon the current status of genetic testing? For that, we need detailed clinical phenotyping to better define the genotype-phenotype correlations. We need to identify other modifiers of the phenotype, which could be epigenetic or environmental in nature. And one of the main drawbacks is that we don't have good models to understand the mechanism of many of the genes that have been identified in CAKUT, how they develop these malformations. So in conclusion, CAKUT is a frequent human developmental defect. The technique to identify genetic causes include NGS method and copy variant analysis through microarray. But these genetic data reveals a very complex genetic architecture of CAKUT, for which we require large collaborative efforts in order to develop accurate genetic testing strategies that can guide clinical decision making. Thank you for your patient hearing, and I would like to acknowledge my lab team members for their work on next generation sequencing. Thank you.